Good morning all and welcome to this presentation about periodontal disease, its classification, diagnosis and management, presented to you by me, Dr. Khalid Azouni, uh, and I hope that this presentation will be an interesting and beneficial one to you. And here, let's start by defining our playground where all these diseases happen. The periodontium, it's a tissue unit that invests and supports the teeth, including these four tissues, gingiva and alveolar mucosa, the cementum, the periodontal ligament, and the alveolar bone. And there is also communication between these tissues, and infections can spread between them. And we should keep in mind also the communications between these tissues and the pulp and periapical tissue, leading into the rise term periodontal endodontic continuum. The communication pathways between the pulp tissue and the periodontium are the dentate tubules, the lateral and accessory canals, and the apical foramen. Now, periodontal disease is a pathologic process affecting the periodontium, most often gingivitis and periodontitis. It's not a single disease, it's several diseases with different pathogenesis, different progress. And gingivitis is inflammation of the gingiva, while periodontitis, inflammation of the periodontal tissue, resulting in clinical attachment loss, alveolar bone loss, and periodontal pocketing. And here we follow with you one case that we followed from 2018 and until 2021. This patient is a lady, young lady, 27 years old, with iron deficiency anemia, vitamin D deficiency, vitamin B12 deficiency. We can see that the patient was undergoing orthodontic treatment since 2018. And with the combination of local factors, plaque and calculus, systemic factors like iron deficiency anemia, vitamin D deficiency, vitamin B12 deficiency, and the occlusal forces during orthodontic treatment, and probably poor oral hygiene, altogether led into development of severe loss of attachment. It doesn't look much in this X-ray view, but if we look at the clinical picture, we can see the amount of tissue loss happening with the recession associated here after cleaning, and we will be talking about this later. Now, periodontal disease is an old disease. Humanity lived with it for a long time, as evidenced for that by various old skulls with signs of splinting and loss of attachment. As in this case, this skull was discovered in Lebanon in the ancient site of Sidon or Saida, and the mandible here is about from around 500 BC. We can see here splinting of the affected teeth by periodontal disease by gold wire, and it is a clear indication that this patient had periodontal disease, close to the case that we shown to you clinically. Here, there is an intriguing historical fact that I would like to share with you. This skull was discovered in Sidon, and it was part of what we, in that time, it was called Phoenicia. And Phoenicia is a famous civilization, well known in the world, that spread through commerce through the Mediterranean Sea, and there is evidence of their ships reaching as far as as Britain now, and doing trade there. And here, now these Phoenicians spread culture and commerce through the old world, and they developed the first maritime empire that rivaled the Greeks and later the Romans, and they were credited by the invention of the alphabet, and all our modern alphabets trace their descent into the original alphabet developed by the Phoenicians. Now, the interesting thing is that the Phoenicians called themselves Canaan, meaning that they are an extension of the Canaanite civilization, which is a Semitic civilization, speaking a Semitic language, the Canaanite language. And we can see how they spread into Carthage, where the famous Hannibal fought with the Romans at early days. We can see how they affected the development of the old world history. Now, let's carry on with periodontal disease. If we move further in history, this is Hippocrates, the famous physician. We all, as healthcare professionals, swore by his oath when starting our careers. And the second most famous author in the Western medicine was Celsus, medical author. He was a Roman encyclopedist and presumably a physician, and he's known for his extant medical work, De Medicina, the only surviving section of a much larger encyclopedia, and with it a discussion on medical knowledge. Part of the things he introduced is a famous cardinal signs of inflammation, and we can see here this illustration of it. We call it the 5 Greeks. The 5 cardinal signs of inflammation: loss of function in case of periodontal disease, loss of attachment, and loss of alveolar bone. And also another sign is pain or dolor, and another sign is swelling or tumor. We observe during periodontal abscesses, for example, and there is also redness, observed as redness of the gums or rubor, and there is heat, elevated temperature, which we rarely see in periodontal disease, if it has, especially if there is a reduced immunity, like in cases of necrotizing ulcerative periodontitis. Now, we see here by clinical pictures. Here sign redness, gingivitis, and periodontitis. We can see also the deposits of the teeth. We can see here a periodontal abscess with pus coming. Here, and the swelling there. There is a thing here. Many people confuse between periodontal abscess and acute necrotizing ulcerative gingivitis and periodontitis, and we will talk about them later. Then there is recession. You can consider this as loss of function. Also, tooth loss, tissue loss of the periodontal ligament, gum, and around the teeth. This is also part of loss of function, and same as this. And these teeth are splinted together because of the loss of attachment, leading into some mobility of the teeth. Now, the spectrum of periodontal disease. Starting by normal periodontium, we can see different shades of it depending on the pigmentation, melanin pigmentation. This is all normal, and it's various. Well, the only difference is the varying degrees of melanin pigmentation, like in the skin pigmentation. And then there is chronic periodontitis with loss of attachment, and there is necrotizing, acute necrotizing ulcerative gingivitis and periodontitis. Here we can see redness, marked redness. There's inflammation. It's marked by pain, usually severe kind of pain, and also bad smell, metallic smell, and altogether it makes it a different presentation of periodontal disease than chronic periodontitis. So we shouldn't mix up between them. Chronic periodontitis is a chronic disease, while necrotizing periodontal disease is an acute disease. Okay, now the severity of periodontal disease. Starting by healthy periodontium with pocket depth less than 3 millimeters, bleeding on probing, no bleeding on probing, and radiographic bone loss, no bone loss. In gingivitis, there is inflamed gingiva, pocket depth less than 3 millimeter, And bleeding and probing there is. In mild periodontitis, there is inflamed gingiva. Here, pocket depth are between 3 and 5 millimeters, and there is bleeding and probing, especially in active disease. And radiographic bone loss up to 15% of root length, or more than 2 millimeter, less than 3 millimeter. Clinical attachment loss 1 to 2 millimeter, and we'll talk about this. And then the definition by the CDC and AEP, which is used in statistics, and here it's neither moderate nor severe. So moderate periodontitis, inflamed gingiva, pocket depth more than 5 millimeter, less than 7 millimeter. There's bleeding and probing, radiographic bone loss from 16 to 30% or more than 3 millimeter, and 5 millimeter. Clinical attachment loss 3 to 4 millimeter. For the statistical CDC definition, more than 2 sites with clinical attachment loss more than 4 millimeter, or more than 2 sites with pocket depth more than 5 millimeter. In severe periodontitis, inflamed gingiva, probing depth more than 7 millimeter or pocket depth, bleeding and probing there is, radiographic bone loss from 30 to 30%, or more than 5 millimeter. Clinical attachment loss more than 5 millimeter. CDC definition more than 2 sites with clinical attachment loss more than 6 millimeter, and 1 site or more with pocket depth more than 5 millimeter. Now, for the pathogenesis of periodontal disease, the famous Chinese strategist Sun Tzu, in his famous book, The Art of War, said that if we know the enemy and yourself, then we don't need to fear the result of battles. It will be a success. But if we know ourselves and not the enemy, then there will be success and defeat. If we don't know ourselves or the enemy, then we will fail in every battle. So that's why we should know the pathogenesis of periodontal disease. And here there is a nice video that I prepared for you. And let's start with it, about dental biofilm, dysbiosis, and disease.
Dental biofilm, dysbiosis, and disease. Ancient Sumerians of Iraq speculated in ancient texts over 7,000 years ago that living organisms called tooth worms were responsible for oral disease. The science of microbiology started in 1683 when Antony van Leeuwenhoek, a Dutch dry goods merchant working with microscopes he developed, reported, "For 3 days I didn't clean my mouth on purpose, and then took some of the matter that stuck on the front of my teeth. I mixed it with spittle and some water, and discovered to my amazement few living animalcules in this. This was the first observation of bacteria, but it wasn't until 1890 that these animalcules, now called bacteria, were implicated in dental disease. Now, let's take a tour in the mouth. No matter what we do, there will be plenty of bacteria in the mouth. In fact, we can't and shouldn't have a bacteria-free oral cavity. Good oral health is about controlling the bacteria that is present in dental plaque. What is dental plaque? Dental plaque is a type of biofilm. These sticky bacterial communities, much like human cities, could be found anywhere in nature where liquid meets a solid surface. By sticking together in these communities, bacteria will be far more resistant to the external environment, like having resistance to antibiotics. About 700 bacteria species are found in the human oral microbiome, and within any normal person, there are 200 to 300 species present. Some of these bacterial species are implicated in dental caries, most prominently Streptococcus mutans. Others are implicated in periodontal disease, as Aggregatibacter actinomycetum comitans, abbreviated as AA, and implicated in rapidly progressive periodontal disease, Fusobacterium nucleatum, Streptococcus micros, Brevotella intermedia, and red complex bacteria implicated in more severe periodontitis, including Porphyromonas gingivalis, Treponema denticola, and Treponema forsythia. Also, some putative periodontal pathogens such as Filifactor aloces and Parvimonas micra. The quantity of bacteria in a person's mouth can be in the billions, which if lined together end to end will span more than a mile, which is taller than the tallest of human skyscrapers. Once the tooth enamel is cleaned, salivary glycoproteins quickly deposit on the tooth surface, allowing pioneering species of fast-growing oral bacteria to bind, colonize, and quickly begin reforming the dental biofilm. Then other species bind and continue to form a thicker and more mature dental biofilm. The bacteria multiply, produce polymers, and communicate with each other, much like humans living in cities, resulting in complex three-dimensional biofilm, like cities building skyscrapers. The early colonizers are beneficial good bacteria. However, they create an environment suitable for the growth of the more slowly growing bad and pathogenic bacteria. Inadequate oral hygiene allows the development of a thicker, more mature, and complex dental biofilm, which can lead to an imbalance between good and bad bacteria in the oral microbiome, a term called dysbiosis. The pathogenic bacteria in dental plaque release toxins and enzymes that triggers an inflammatory response in the gingival tissues, marking the beginning of gingivitis. According to the World Health Organization, most children and adults have gingivitis. If left untreated, gingivitis may progress into periodontitis with loss of alveolar bone and formation of periodontal pockets and gingival recession, ultimately leading to the loss of teeth and an increased risk of systemic disease. Severe periodontitis is the sixth most prevalent medical condition worldwide. Dysbiosis can also occur with a different spectrum of oral bacteria known to cause dental caries. In most countries, dental caries affects 60 to 90% of school children. Many bad bacteria can cause oral malodor when they degrade food compounds as hydrogen sulfide, which smells like rotten eggs, methyl mercaptan, and dimethyl sulfide. These odor-producing bacteria colonize areas of the mouth that are difficult to reach, like the posterior third of the tongue, which is the primary source of oral malodor. All these oral disorders can be prevented by keeping your oral bacteria in check, preventing plaque accumulation and maturation. Evidence-based daily oral hygiene is achieved by cleaning tooth surfaces using oral brushes, manual or electronic, regularly with a proper method. Yes. Which removes further dental plaque missed by brushing. Rinsing by an effective mouthwash can reach further areas of the mouth that are difficult to reach by other oral hygiene methods. This daily routine will help to maintain a healthy oral biofilm and help to prevent dysbiosis and disease. Make sure to use correct oral hygiene methods, use safe and effective products approved by the health authorities, and do regular checkups with your dentist to help keep your mouth healthy.
Okay,
Dental biofilm.
now we move on into further discussion of the pathogenesis, the homeostasis of periodontal tissues between normal and abnormal dysbiosis, like we discussed before. Um, while we have dysbiosis and the prevalence of pathogenic bacteria, we see the activation of the immune reaction by the body, the cytokines, the neutrophils, macrophages, and other cells, T lymphocytes, B lymphocytes, dendritic cells, osteoclasts. All this will build up in the periodontal pocket, which will deepen with time, and with the production of these cytokines and the reaction of the immune cells, especially the osteoclasts, bone resorption will happen, and further loss of periodontal attachment will happen, and then we go into periodontitis. Not all patients will progress into this stage of periodontitis. Many of them will remain in the stage of gingivitis unless they have some other factors, like, for example, the presence of some specific pathogenic bacteria or um, some defects in the immune response leading into destruction of the alveolar bone and loss of attachment. We can see also the bacteria complexes here, from the early colonizers into the late colonizers, and they are developed into complexes. We can see the different complexes, and we can see from them streptococci are part of them, where you can see these are all early colonizers. The blue, the purple, the green, and the yellow are all early colonizers, and these are middle colonizers that develop in more mature plaque with the passing of time, and then there will be buildup of certain harmful bacteria like Porphyromonas gingivalis, forsythia, and Tribonema denticola, and maybe AA actinomyces, actinomycetum comitans later, and the development of more severe forms of periodontal disease. Now, these are part of the pathogenic bacteria that are associated with severe forms of periodontal disease. Porphyromonas gingivalis, the colony view, and electron microscope view. Now, what's the difference between them and the other bacteria? They have certain virulence factors. They produce, for example, toxins. They might be able to evade immune response of the body and cause a reaction in the, or maybe they can invade the periodontal tissue, like in Aggregatibacter actinomycetum comitans, formerly known as Actinobacillus actinomycetum comitans. We can see the microscopic view and the colony view of it. And as we see, it's a gram-negative bacterium. Now, the role of the immune system that we discussed, active in periodontal health, the cells that are active. In periodontal disease, there is activation of certain bacteria and certain cells of the immune system associated with the development of cytokines, inflammatory cytokines, leading into recruitment of other immune cells, including the osteoclast activation and bone resorption. And now, the model for periodontal disease pathogenesis in 1997, the metabolism of connective tissue and bone, and the host inflammatory response. There is an interaction between them. In periodontal disease, initiation and progression, it's affected by microbial challenge and the presence of risk factors, including genetic factors and environmental and acquired factors, like, for example, antibodies and antigens, and lipopolysaccharides of gram-negative bacteria and other factors, cytokines, inflammatory mediators, prostaglandins, matrix metalloproteinase, and then periodontal disease will result and might also affect the buildup of bacteria and increase bacterial challenge. And also here from these matrix metalloproteinases, there is a kind of periodontal treatment line, which is the immunomodulation therapy. And then we can talk about the periodontal balance with all these virulence factors, risk factors, genetics, overpopulation, pro-inflammatory mediators, underactivity and overactivity aspects of host response, poor compliance, poor plaque control, subgingival bioburden. In health, there is more of the healthy factors, host immunomodulatory therapy, for example, resolution of inflammation with improvement of oral hygiene, treatment like oral hygiene instructions, scaling root planing, surgery, antiseptics, antibiotics, in some cases to reduce bacterial challenge. Altogether, might tip the balance toward health and back to normal or reduced periodontium. And then here we can see the gingival sulcus and the periodontal pocket. We can see the bacterial challenge, some bacterial invasion and activation of the immune response of the body, immune cells coming from the blood vessels in the periodontium, and then activation of the osteoclasts with bone resorption. All this. And in the circulation, there will be production of, there will be some viable bacteria coming from the pockets, and this is tested theory. And there will be also some bacteria products like the lipopolysaccharides of gram-negative bacteria and the presence of pro-inflammatory mediators, leading into increased risk of development of disease in certain organs, like, for example, atherosclerosis, heart disease, obesity, stroke, Alzheimer's disease, pulmonary infections, like, for example, in the recent days, the COVID, more prevalence of severe COVID-19 in patients with periodontitis, inflammatory bowel disease, colon cancer, diabetes, and pregnancy complications like early low birth weight, and rheumatoid arthritis. All these diseases are linked statistically to periodontal disease, with patients having periodontal disease more at risk for development of these diseases, and this is the way how it is done. Okay, so this adds more weight into the need of treatment of periodontal disease and improvement of oral hygiene by eliminating plaque and calculus. So if your dentist tell you you have periodontal disease, you should be concerned and take care of yourself by treating it and improving your oral hygiene so that you will be less at risk of developing these systemic diseases. Now, the effect of periodontal disease. Attachment loss. It's measured by periodontal probes, different kinds of periodontal probes here. The neighbor's probe is for the furcation, measurement of the furcation, while the other probes are for measurements of pockets. And then we measure the probing pocket depth, and by correlating it with the distance from the cement to enamel junction to the base of the pocket, we lead into the clinical attachment loss, which is the pocket depth minus the gingiva covering the cement to enamel junction, or in case of recession, it's the probing pocket depth with added distance of recession, the distance from cement to enamel junction to the gingival margin. So in total, clinical attachment loss is either the pocket depth minus the distance from gingival margin to the cement to enamel junction in case of gingival overgrowth, or it's a probing pocket depth plus the distance from gingival margin to the cement to enamel junction in case of recession. And the other effect is the bone loss. We can see here the different kinds of defects, one wall defects, two wall defects, three wall defects, and the circumferential defect, where we count the walls of remaining alveolar bone. It will affect the prognosis and the success of treatment by regeneration, for example, where the more bony walls means the more chance of reducing the attachment loss by bone grafting and guided tissue regeneration. And then the furcation involvement and its classification. Two classifications, the horizontal one like Lickman and Hamp, grade 1 and grade 2, which is more deep, and grade 3, which is through and through. Grade 4, it's like grade 3 through and through, but with gingival recession leading into exposure of the furcation. Add to it the vertical component, which is the probing pocket depth. The vertical classification by Tarnow and Fletcher with subclass A 1 to 3 mm, subclass B 4 to 6 mm, and subclass D more than 6 mm. Combine them together and then we get the furcation involvement grade, for example, 1A or 2B or 1C, depending on both components, the vertical and horizontal components. And then here we can talk about the bone loss assessment, conventional radiography, 2D radiographs, advanced radiographs with advanced techniques, deep learning, the AI now coming into everywhere, including this deep learning based diagnostic systems, radiographs and assessment, and the 3D CBCT with 3D volumetric reconstruction, where we can see the status of the bone from the X-ray before doing a surgery. All these diagnostic techniques are available to us and help us in reaching a diagnosis. Now into the classification. The earliest classification of periodontal disease that we talk about is the one in 1989, where the interaction from health and gingivitis to periodontitis with different kinds of periodontitis, adult periodontitis and the early onset periodontitis, prepubertal, juvenile, and rapidly progressive. This is according to the age of the patient. There is also systemically predisposed periodontitis and necrotizing ulcerative periodontitis and refractory periodontitis. The next classification was the 1999 classification, and it divided periodontal disease into necrotizing periodontitis, chronic periodontitis, aggressive periodontitis, and periodontitis as a manifestation of systemic disease. And here we should keep in mind that chronic periodontitis and aggressive periodontitis introduced in 1999, they are both chronic diseases, not acute. Necrotizing periodontitis is an acute periodontal disease, while chronic and aggressive periodontitis, both of them are chronic diseases. What's the distinction? Chronic conditions develop and worsen over an extended period of time, as in atherosclerosis, while acute condition symptoms appear to change and worsen rapidly, like in a heart attack. Chronic periodontitis and aggressive periodontitis develop over time. The only difference is that aggressive periodontitis is quicker. So chronic periodontitis is like low speed disease. Aggressive periodontitis is higher speed, but both of them are chronic diseases, unlike necrotizing periodontitis. So don't go and talk about acute gingivitis. Rarely we'll find this unless it's acute necrotizing ulcerative gingivitis, or is it a gingival abscess? It's still a chronic disease. Okay. Now, chronic periodontitis, mostly in the adults, slow rate of progression, while aggressive periodontitis, rapid rate of progression, mostly in younger patients. Elevated proportions actinobacillus, actinomycetum comitans, porphyromonas gingivalis, phagocyte abnormalities, hyperresponsive macrophage, progression of attachment loss, and bone loss may be self-arresting. So that's a feature of periodontal disease, that it goes in bouts from reduced activity to increased activity, and the accumulation of this will lead into the progress of disease. So chronic periodontitis, progressive attachment loss and bone loss, pocket formation, and it's the most frequently occurring form. It's prevalent in adults, can occur at any age, usually associated with the presence of plaque and calculus. The progression occurs slowly, with periods of rapid progression sometimes happening, associated with variable microbial pattern. Aggressive periodontitis, rapid attachment loss, and bone destruction usually happens at younger age of onset, but it might happen at older ages. Increased proportion of actinobacillus, actinomycetum comitans, or Aggregatibacter actinomycetum comitans, porphyromonas gingivalis, phagocyte abnormalities, microbial deposits inconsistent with the severity of tissue destruction, meaning patients might have little plaque and calculus but severe attachment loss. Necrotizing periodontal disease, infection characterized by necrosis, gingival tissue, periodontal ligament, and alveolar bone. These lesions are more commonly observed in individual systemic conditions, like, for example, HIV, infection, malnutrition, immunosuppression, and we'll talk about it. So, now the latest classification was introduced of periodontal disease was introduced in 2017. Why we put here chess set? Because it is